Shannon will be here in a minute. He just stepped out, maybe to get me coffee. All right. So on the schedule, we had anti-anginals, and you saw that we did the anti-anginal lecture the other day. I was actually ahead of schedule for once, and so I was actually pretty happy about that. We're going to spend a little bit of time today on the anti-arrhythmic drugs. So up until now, we've been talking about the pharmacology for cardiac diseases from, I would say, from an internal medicine standpoint. All right, so basically, no matter what discipline you go into in terms of your professional career, all of those drugs will be kind of your responsibility in some shape or form. The anti-arrhythmics, this is kind of where we delve into the more specialized cardiac disciplines. And so, there are specialists who deal with patients that have arrhythmias, and they're the ones responsible for prescribing the majority of these medications. So your job, if you were internal or family medicine, would be to understand how these work, and then basically relate some of the side effects and toxicities to what the patient is presenting. So you may not be the one prescribing these medications per se, but you'll definitely be the one kind of managing some of their therapies. And so what we decided to do was we decided to kind of combine the physiology of some of these receptors with the pharmacology to kind of put things in order from a very kind of fundamental, basic science perspective. And then as we go through, I usually have like a small mini summary presentation. I couldn't find it to post it with this. If not, I'll just write a new one. But to kind of maybe consolidate all these things, and we'll put that up together by the end of the week. Just because it's, there's not that many drugs here, but it is a little bit confusing. Okay? Learning objectives. And so just kind of some nomenclature. When we talk about arrhythmias, there's really two types that are used clinically, two distinctions. And one is supraventricular. And so basically these are arrhythmias that occur above the ventricle. So what's above the ventricle anatomically? The atrium, right? So another way of describing a supraventricular arrhythmia is an atrial arrhythmia. All right, one and the same. The other would be on the bottom portion of the heart, which would be the ventricular arrhythmias. And so these are arrhythmias that occur specifically in the ventricles. All right. Other descriptors in terms of cardiac arrhythmias include these two-word anomalies. So the first word is the anatomic location of where this cardiac abnormality takes place. So is it at the SA node? Is it at the AV node? Is it within the ventricular muscle fibers itself? And the second word describes the pace of the arrhythmia. So is it slow? Is it fast? Is it delayed? Is it fibrillating, or is it fluttering? Okay, so each of these, so you can get a supraventricular fibrillation, you can get a ventricular flutter, ventricular tachycardia, and so forth. Okay, and these are the things that you would see. So this is what these look like, and by now you guys have at least started to kind of examine the EKG. Of course, this one you'll recognize as normal rhythm. And I like this diagram. This is coming from Goodman and Gilman's Pharmacology Bible. I like this diagram because it gives you an example, and they're all on the same slide. So you can kind of compare the different EKG abnormalities based on the size and the frequency of some of these peaks. So here's an example of a premature ventricular beat, paroxysmal supraventricular tachycardia. This basically means this is a supraventricular tachycardia, or PSVT, that comes and goes. This is a fib, good example of that. Here's a flutter. Notice all the different P waves. A flutter with a one-to-one conduction. Here's a nice example of torsade de pointe. And of course, the very deadly ventricular fibrillation. So here's a nice kind of example summary of all the different EKG abnormalities. Understand that when we talk about some of the arrhythmias, we're going to start talking about the influx of ions. And that's pretty much kind of the impetus of this lecture, is looking at the movement of ions across some of these cells and what that means in terms of membrane potential. And so I kind of like this diagram. This really kind of shows the SA node specifically, looking at membrane potential over seconds. And so this tracing, this physiology tracing, is looking at the flow of these ions through the SA node. And this is what this looks like. So here's kind of that threshold in terms of minus 40 millivolts. Okay, and at this point now the sodium is leaking into these cells. Okay, and that is bringing this threshold to increase. And at this specific point, you've got these calcium channels beginning to open, and that gives way to the potassium channel opening, which increases the membrane potential into the positive. And then we've got a decrease after these potassium channels have opened, and the process repeats again. And so this tracing is very specific to the SA node. These fibers are inherently leaky to sodium, and this is the thing that, bless you, that kind of drives the self-excitation in terms of pacemaker activity. Okay. Likewise, here's the tracing for the ventricular muscle. The shape is a little bit different, looks like this. And notice the membrane potential starts a bit lower, goes down to minus 80 millivolts, and then goes up to plus 20. And here you see the first sodium channels begin to open. Okay, this is associated with phase 0. Potassium channels open as we proceed to phase 1. Get a slight decrease in membrane potential. This is when the calcium channels open more. This is responsible for kind of the prolonged repolarization. And then here, as we proceed to phase 3, now we've got the potassium channels involved. And then, of course, membrane potential plummets. And then we reach baseline. And then that process occurs again and again. And so this is kind of the tracing that you see for the ventricular muscles, and that shape is privy to ventricular muscle action potential. All right? And so in terms of action potentials, with each action potential, you've got the myocyte loses potassium and gains sodium. And this is maintained by that sodium-potassium ATPase pump, which is actually a viable molecular target when you look at how digoxin works. This increase in calcium around phase 0 favors the release of even more calcium from the sarcoplasmic reticulum, and that was the thing that was responsible for that increase in contractility that we associate with, the beta-1 receptor opening up to calcium, and then all that calcium influx is responsible for kind of maintaining that, or providing the stimulus for the cardiac recontractility. And of course, the refractoriness is always important, and we'll come back to that concept again and again. In terms of when we talk about refractoriness, it's really the amount of time that it takes for an excitable membrane to get ready for a second stimulus. Okay? Do you guys remember back when we talked about acetylcholinesterase inhibitors and acetylcholinesterase at the synapse, looking at the acetylcholine and the muscarinic receptor? We said that acetylcholine in very, very large doses can actually kind of change the refractory period of the receiving end of whatever cell has the muscarinic receptor. And so, there was a two-phase mechanistic approach to, really high amounts of acetylcholine offering or altering the refractory period of that cell. And this kind of basically reiterates that point. And so some of these drugs, and you can see this example here, here's a sodium channel blocker, minor changes in the refractory period, but other, more dramatic action potential prolonging drugs can actually shift the whole curve to the right. And that's really going to change the amount of time that muscle can be re-excited from a recent repolarization. Okay? And so clinically, what they've done is they've basically assigned the main antiarrhythmic agents into 4 main classes. The first class are the drugs that can block the sodium channel, okay? And the subclasses that are underneath it, there's 3, ABC, basically refer to what kind of an effect the sodium channel blocker has on the action potential, all right? The second group are sympathetic beta-1 antagonists, okay, which can act as antiarrhythmic drugs. The third group are drugs that prolong the effective refractory period, and these are potassium current altering drugs. And then finally, the fourth group of drugs are the calcium channel blockers. Okay, so all 4 of these drug classes can be and are used as antiarrhythmic medications. All right, and so there's a couple of generalities that you can kind of look at. If you look at the Vaughan-Williams classification, and kind of the different physiologic outcomes. All of these different drugs are kind of rated differently, and this is kind of where the ambiguity kind of exists. And so, the class 1A agents have physiologic effects on both the atrial muscle as well as the ventricular muscle. Okay, this would be in contrast to the class 1B agents, which primarily only affect ventricular muscle. So right off the bat, if you've got a ventricular problem, either of these agents would probably be okay, right? But if you have an atrial problem, a class 1B agent really won't affect that that much. And of course, we can look at the efficacy. So how potent are these drugs? And so some of these are more potent than others. How toxic are these drugs? That's really kind of the key difference here. And so when we talk about therapeutic index, remember we talked about some drugs have a really wide therapeutic index. Most of these drugs have a relatively narrow therapeutic index. And that's because the efficacy and the toxicity are very close. Okay? One of the key annoying aspects of these drugs is that when inappropriately used, either due to a bad diagnosis or bad dosing schedule, the potential for arrhythmias can be increased. All right, and that's really problematic because here you've got a drug that you're trying to treat an arrhythmia, and when it's inappropriately used, can actually induce an arrhythmia. So then why bother treating, right? Exactly, that's probably what you're thinking. You know, these drugs do have their specific uses, but one of the easier ways to actually treat arrhythmias is to actually anatomically find the circuitry that's responsible for producing these arrhythmias, this faulty conduction pathway, identifying it electrophysiologically, and then ablating it. Okay, and there's different ways you can do that, but ablation essentially means identifying that false circuit, and then literally killing it. And so if you can't physically do that, or if it didn't work, or the patient maybe won't handle the surgery, these are the drugs that exist to kind of manage those patients. Okay. So we're gonna here's the outline. So we'll start with class 3 agents, and these are the potassium channel blockers. Then we'll go to class 1, 2, and 4. All right, and so there was a reason for this. Essentially, you know, Dr. Shannon thought that, you know, in terms of ease of explanation, we'll kind of provide them this way. We're in no composure to put the Vaughan Williams classification in its correct order. So we're going to do it based on a logical sequence. All right. So let's look at the class 3 agents. So these are the drugs that exist to essentially prolong the action potential. All right. And these are, again, the potassium channel blockers. And these are the ones that are essentially characterized to increase the action potential. And you can you can physically see this by an increase in the QT interval. All right. And so these are really good for reentry circuits where there's a circus movement where instead of it going from point A to point B, now it goes from point A, point C, D, F, G, and then B. And so these reentry circuits or these circus movements can be molecularly targeted by using some of these potassium channel blockers. All right. So here's the membrane, the electrical gradient and the concentration gradient. And essentially what we're doing is we're moving kind of potassium out of the cell and we're moving sodium into the cell. And these gradients are the things that are kind of driving some of these faulty electrical pathways. And so what we're going to do is we're going to kind of slow things down or speed things up depending on which drug class we're going to talk about. And hopefully control some of these arrhythmias as they become manifested. All right. So as we transition now, so we're basically setting up the potassium-sodium current, and let's talk a little bit about the potassium channels themselves. You guys remember Dr. Shannon? Okay, of course.
So you guys remember probably this figure. This is our action potential, our ventricular action potential up top. These are our currents on the bottom. Remember, a downward deflection is an inward current. That means positive charge coming in. That means depolarization, right? More positive charge inside, membrane voltage goes up. So if you're sitting at rest, I'm a myocyte, sister's over here, brother's over here. There's an action potential propagating down my sister. It hits the intercalated disc. It depolarizes my membrane, my sodium channel's open. I get a humongous increase in sodium, right? Sodium coming into the cell, I get this huge depolarization really fast. And remember, the rate of that depolarization is dependent upon the rate of the influx of the positive ions. In the case of sodium, it's massive. This doesn't look very big here, and that's because unlike the rest of these currents, it's 1/50th of the normal size. If it was the normal size, it would go all the way down through the floor of the lecture hall, okay? So you've got that. That's phase 0. Phase 1 and 2, you have your potassium currents flowing, and that's what we're going to talk about here, right? So your potassium currents are outward currents. That means positive charge leaving the cell. Potassium going from inside to outside. that means your potassium channels are trying to make your membrane voltage more negative. They're trying to bring it down back toward rest. And during phase 2, in particular, the plateau phase, that's opposed by positive influx through the sodium-calcium exchanger, 3 sodiums in, 1 calcium out, and through the calcium channel. And we're going to talk about calcium channel blockers a little bit later. The calcium channel is trying to keep you depolarized. So you've got a tug of war going on. And eventually the potassium channels win, primarily your IKS, which is a delayed rectifier. That brings you into phase 3, and that brings you back down to rest where your inward rectifier is most active, okay? So that was a really quick way to go through what was an entire lecture last year. So we're going to talk about the potassium channel blockers, and again, those are outward currents, and we're talking about them being active mostly during the plateau. So you guys remember from last year, if you decrease the potassium current, let's say, for instance, we had long QT syndrome 1, where there was a mutation in the slow potassium delayed rectifier, IKS, and that resulted in a longer plateau phase because it took longer for the delayed rectifiers to finally overwhelm the calcium current in the sodium-calcium exchanger, and it extended that plateau phase. Okay? And what that means in terms of what Dr. Broderick was just talking about, it extends your refractory period, which means it extends the period of time that you have before another action potential can depolarize that membrane. And in the case of arrhythmias, that's frequently the cause of the arrhythmia. You're getting a depolarization when you shouldn't get it. So you keep the membrane more refractory longer, it can't be depolarized during that time. So let's take a look. This is a big diagram for me because it explains an awful lot. So ordinarily, you have your action potentials. They're propagating down along whatever pathway we're talking about in the ventricle. You guys know it spreads out. And in here, this little triangle, that's not excitable tissue. Could be just a lot of collagenous tissue or, you know, some other sort of insulating tissue that really isn't excitable. It could be a site where you have a myocardial infarction where, you know, you've cut down on the oxygen, the tissue's not as excitable and it doesn't travel through. So that could be extremely bad. Because what happens is, this is normal as well, you get this depolarization, and what it does is it just goes around the point where you're not getting a propagation. And it goes around, and you guys can see it spreads out along another distal pathway. And these two waves, they separate at X, but they come together right here, and they basically just annihilate each other. So nothing bad happens. They just go around and come together, and they hit each other, and that's it. All the tissue's depolarized. Okay? And meanwhile, you've got continued propagation out here and here. Okay? Not a big deal. That's how normal tissue works. Well, if you get an area of ischemia in what would normally be conducting tissue, this alpha and beta pathway, they don't conduct action potentials at the same rate. You get what's called a unidirectional block. And what that means is that the action potential splits at X, but it can't go down this beta pathway. It only goes down the alpha. So now it comes back around, comes up through here through this distal pathway, and then back up the beta in the wrong direction. Okay? And it doesn't really want to travel up that beta pathway all that quickly if it's damaged tissue, but it still does it. Okay? And how slow that propagation is a big deal. If it's slow enough, then what happens is that that wave comes around and, or if it's fast enough, that wave comes around and it hits this alpha pathway again while the alpha pathway is still depolarized. And that means while it's still refractory and it can't be re-stimulated. So in that case, your wave just stops, okay? It's annihilated just like it was before, no big deal, no harm done. But if it's slow, and the worse this damage is, the slower it is, then what happens is you come back around and you hit this alpha pathway after it's recovered. And if you hit it after it's recovered, you re-excite it. And you re-excite it, and the wave goes down the alpha, back around, up the pathway, re-excites the alpha again, comes around, up the pathway. What you've got is an arrhythmia. You've got a bunch of depolarization going on in these branches that shouldn't be there. Those waves should have annihilated and just stopped, and then you should have allowed repolarization. Well, repolarization can't take place as long as you've got this wave of depolarization going around and around, okay? So this is called a reentrant pathway. So if you look at this, you can see how a potassium channel blocker, a class 3 anti-arrhythmic, might really help. Because what's happening is you increase the refractory period in this alpha branch. And so even though the propagation back up this beta branch might be slow, if you can keep the alpha depolarized for long enough, it'll come back around and it'll hit this alpha branch while it's still depolarized. So you're lengthening that refractory period. You're lengthening the amount of time that can go by before it repolarizes and can be re-excited. And so even though this beta pathway is slow, maybe you can keep this alpha pathway depolarized long enough to where it'll stop the depolarization and prevent a reentrant pathway, okay? That's basically, in theory, how these work, okay? So what you're doing here is you're lengthening the action potential, you're increasing the refractory period, and you're decreasing reentry, okay, in theory, all right? Back to you, sir.
Thanks. And just a quick point there. I think that's like the key diagram right there, that whole reentry circuit. So as clinicians and as cardiologists, when they're looking at the arrhythmias that are present, majority of the arrhythmias, whether they're ventricular tachycardias or supraventricular tachycardias, if you're asked what their mechanisms are, the predominant mechanism is reentry. It's a reentrant arrhythmia. There are some other minor mechanisms that you guys will and so forth, but this is probably the main reason why. And where this reentry circuit is arrhythmias that you see. So if you have a diseased ventricular tissue and you put the reentry circuit in the ventricular tissue, remember what's the intrinsic ventricular rate in that 25-30 range? You put a reentry circuit there, that's that V tach that you saw. You put it in the AV node, you have AV nodal reentrant tachycardia. You put this all over the atrial tissue, you have atrial fibrillation. So that's the concept. So tying in, I mean, this is sort of going from sort of like the base to clinically what do we see. So majority of arrhythmias that we do see, there's a few other mechanisms, and this is probably the hallmark way of explaining this. I always have a tough time explaining this to students, so I will be referring everybody to this PowerPoint, this slide, this page, this.
Thanks, Dr. Shaw. So what are these potassium channel blockers? So mechanistically, they all pretty much have the same mechanism. So we're going to block this potassium channel in the cardiac muscle. And these drugs are listed here: amiodarone, dronedarone, ibutylide, dofetilide, and sotalol. Okay? And probably the most clinically relevant, the most important drug in this group is number 1, amiodarone. It's the most potent out of all of them, okay? And it has a lot of uses for a whole bunch of different cardiac pathologies. The problem is that it's so potent, it also has a lot of side effects, okay? And so it's kind of a double-edged sword between treatment and therapy, but let's kind of examine a little bit more of these. So amiodarone is actually structurally similar to the thyroid hormone. So you can imagine what some of the side effects would look like. And those are linked to basically interactions with the nuclear receptors that are associated with the thyroid hormone receptor. Amiodarone itself is lipophilic, and it goes to fatty tissue. All right, and this is kind of a difficult in terms of pharmacokinetics because it'll go into the tissue relatively slowly over the course of several doses, but it also leaves slowly. So that's kind of a problem. So if you think of an overweight or obese patient and the fact that they have amiodarone on board, there can still be some of this drug persisting well after the last dose has been given. In terms of oral administration, it's great. It'll restore the SA rhythm to patients that have atrial fibrillation. If you give it IV, it can actually terminate ventricular fibrillation or ventricular tachycardia relatively quickly. Okay, so what's the difference between those two? Patients can live with AFib, you know, for hours, days, weeks. How long can you live with VFib? Was it 3 minutes? 2 minutes, if that, before they go into full cardiac arrest? Okay, hence the oral administration of amiodarone for rhythm control, and then IV administration of amiodarone for acute termination of VFib, because you only have a few minutes. And so, as we said, amiodarone can be given orally or IV, and mechanistically, it's going to prolong that action potential that Dr. Shannon talked about, and the QT interval by blockade of this specific potassium channel. Even though it's described as a class 3, and this is where this gets really tricky. So the Vaughan Williams was basically made to make learning antiarrhythmics easier. I think it actually made them harder. Even though amiodarone is a class 3, it will also block sodium channels. It will also block beta receptors, although weakly. And it will also block calcium channels, albeit weakly. Okay, so even though it technically is a quote-unquote potassium channel blocker, it has principal outcomes in the other 3 categories, which makes it, in terms of the Vaughan Williams, kind of annoying. So what will happen physically if you give a patient amiodarone? It's going to slow both heart rate, okay, but it'll also slow the AV nodal conduction velocity or the frequency. You will get some peripheral vasodilation if you give it IV. Maybe it's the solvents. Can't really explain it at this point. With patients that have pre-existing sinus or AV node disease, specifically bradycardia, and heart block, this might occur. So you might get some of these side effects coming up in certain other anomalies. As you said, amiodarone can accumulate in many tissues. There's a dose-dependent pulmonary toxicity. There's deposition in both skin and eyes, and so with the skin, you can have some photosensitivity, especially if you give it in the summertime or in a warm area. This wouldn't probably be an issue in November in Chicago, because it's usually dark for the whole month. Eyes, you can see corneal deposits, and then there can be visual disturbances as well. And then, of course, there is a thyroid hormone side effect as well. In the periphery, it can actually block the conversion of T4 to T3. So patients that are on kind of long-term amiodarone therapy, you would expect to see disturbances in their thyroid hormone levels. It has variable bioavailability, hepatically metabolized, of course. And the half-life complex is a little odd because you said it spends a lot of time in fat tissue. So the one component can be anywhere from 3 to 10 days. The other component, or the other metabolite, could be several weeks. So this thing will be sitting around for quite some time. It's a substrate for CYP3A4, so there's lots of drug-drug interactions. And the effects of this drug may persist for several months, depending on the patient's physiology and so forth, because it could be hiding in their fat. Bless you. Dronedarone, which is a derivative of amiodarone, the exact mechanism of action is unknown. It shares properties of all 4 drugs within that category, and it's structurally similar to amiodarone. It was kind of the precursor molecule. This will block sodium channels. It'll block beta-1 receptors. It'll alter adenyl cyclase activity, so it's a negative inotrope. It'll block the potassium in a specific channel, and it'll eventually prolong cardiac repolarization. And like its cousin or sister, amiodarone has CYP3A4, or dronedarone has CYP3A4 metabolism. Okay, and basically with dronedarone, you can see kind of the use of this in kind of paroxysmal or persistent atrial flutter, and it's been shown to reduce hospitalization in patients that have sinus rhythm problems. Right. Other drugs within that class 3 category include Bertilium, which is listed here. It was first used as an antihypertensive agent a while ago because it actually interferes with the release of catecholamine. So this is actually much more earlier than the receptor. This is the actual noradrenergic neuron secreting norepinephrine and epinephrine and so forth. So Bertilium actually interferes with the release of any of these catecholamines. When you give it systemically, it'll lengthen the ventricular but not the atrial action potential. and it has kind of an effect on those ischemic cells. And so depending on like the length of the infarct or the amount of the infarct, you can kind of see that there could be, you know, dramatic changes in how a patient will respond to that. What's interesting about this drug is that when you give it, it first causes a surge of catecholamines when it's first given. So it actually, at initial, the first dose is a positive inotrope. And so when it's used by itself, it can precipitate arrhythmias. And so guess where this falls on the ladder in terms of, you know, your first go-to drug? It's way in the back shelf. Okay, so it exists, it's clinically relevant for specific diseases, but it is in no way your first pick. Okay. My major side effects, of course, as you would expect, postural hypertension, hypotension, sorry. And of course, you would treat that with your co-administration of a central agent, which we haven't talked about, such as a tricyclic antidepressant, protriptyline. Okay, so where do you use beryllium? Crisis situations after lidocaine and cardioversion have failed. So there's other drugs that are kind of, you know, your first or second choice drugs. Beryllium would physically be number 3. Okay, so it exists, it's out there. We talked about it, we're done. Okay, the fourth drug, or the last drug on that list was sotalol. So based on its name, what do you think it is, sotalol? Right? Of course, it has some beta blocking effects. And so actually this drug was discovered as a beta blocker, and it is. Only the left-handed version is the beta blocker. The D version, or the D isomer, has the action potential effects. And so that's really why it's kind of both a beta blocker and a class 3 anti-arrhythmic. So this is one that has kind of shared activity. Oral absorption is great. Half-life is about 12 hours. So you can still see it used clinically. The final group would be, the final potassium blocker would be dofetilide. And this one is the one that blocks those delayed rectifier potassium channels. It'll cause hypokalemia. Real slow rate of recovery after blockade exists. And so it's okay to use. It'll maintain normal sinus rhythm in patients that have AFib, and it'll prolong that QT based on plasma concentration. So you can directly correlate the side effect with how much drug was given, which makes this drug relatively useful in terms of its clinical management, because you can actually kind of guesstimate where that QT prolonging effect is going to occur based on the patient's plasma concentration. So that's relatively a useful drug. I still say dofetilide is probably maybe second on the list after amiodarone. Ibutylide is another one that'll kind of be used clinically. It'll block that slow inward sodium current through another mechanism. And this drug is really good at kind of converting atrial flutter and atrial fibrillation into normal sinus rhythm. But the adverse effect, of course, would be a QT elongation. Metabolically, it's secreted by the kidney, so if there's any dramatic renal health consequences, you may want to maybe avoid this drug. And it's also cleared hepatically as well, so there's both a real potent clearance of both liver and kidney on this particular drug. And so this kind of basically just summarizes the clinical pharmacology of the class 3 agents. Okay, GI absorption, elimination, half-life, and the dosage range. Of course, for this particular lecture series, you don't have to worry about the dosage. We're not there. We're not there yet. Okay. This one, sorry, it looked better on the other slide, but this is looking at the electrophysiologic properties of these class 3 agents, comparing amiodarone, sotalol, ibutylide, and dofetilide. Okay, and we can go through some of this as we go through. We'll go through the whole lecture series, but essentially what we're looking at is, you know, efficacy, outcomes, and the ability to treat some of these different conditions. Okay, so that was kind of a summary of all of the class 3 agents. There's only really 4 that are clinically useful. Now we're going to switch gears and look at the class 4 agents, and these are the calcium channel blockers, okay, which is another molecular target that we could use.
I think this might be out of place. Let's make sure. Yep.
Oh.
So if you want, we'll come back to that when we do class 4.
Sorry.
And I'll just introduce the class 4.
Oh yeah, this is the one where we.
Yeah, there's.
You want to? Okay, so we'll come back to.
It's up to you.
Well, yeah, we'll come back to sodium or calcium channel blockers. Let's do the sodium. Okay. Oh, this must be the one from the second year. Okay. All right. Okay. Yeah, you're right.
I think it's just that.
Yeah, it's that one slide. So let's talk about the sodium channel now. Okay, so there's three different classes or subclasses of the sodium channel blocker, and really the difference between these agents all basically look at the membrane repolarization shape of this curve. And so the class 1A agents, there's relatively moderate sodium channel blocking, but there is a kind of a prolonged repolarization. The class 1B agents, there's relatively mild sodium channel block with a shortened repolarization, and the class 1C agents basically show a marked sodium channel blockade and no change in the repolarization. So really it comes down to kind of, the kinetics and how they relate to their ability to change both the sodium channel itself and their effect on repolarization of the SA node. All right. And so if you look at the degree of transmembrane potential, basically comparing drug to non-drug, you can see that the transmembrane potential is going to shift. Okay, and these premature stimuli basically get organized. And so the kind of the analogy is like herding cats. So the arrhythmia is kind of like herding cats, which is damn near impossible. But when you put the drug on board, it's kind of like herding, I don't know, what's an easy animal to herd? Sheep, right? Sheep or goats. Sheep, they lend themselves to be herded, which is why we've been doing it for thousands of years. And so this is what this electrophys basically kind of looks like. And so you get all these different circus movements. And what this does, these drugs do, is that they essentially restore order to some of these really excitable tissues that are completely out of focus. And so now we'll look at the sodium channel in a little bit more detail next.
Okay. So, as Dr. Broderick said, we have three different classes. I hate class 1 antiarrhythmics. I do, because they're confusing as heck. I used to get M2s that would come into my office before Dr. Broderick was here and explained it more clearly, I think. And they'd go, what is going on here? And they could never understand it. And the reason is because these things they do what apparently is like the opposite thing. And you're like, how can it be an anti-arrhythmic and shorten the action potential here and lengthen it here? And the key is to understand what mechanism you're looking at and what you're using the drug for, okay? So these sodium channel blockers, let's recall, here's our AV nodal and SA nodal action potential. Let's start there, okay? We have our phase 4 depolarization, as Dr. Broderick mentioned, all right? And you guys will remember that depolarization, it's really dependent upon a number of different factors. There's a little bit of calcium influx there. The sodium-calcium exchanger is mediating a little bit of depolarization there. It has an effect. What the calcium channels are doing has a little bit of an effect. It certainly affects the threshold potential. We'll talk about that in a minute. But a big part of that depolarization is caused by the pacemaker channel. Remember IF, the funny current. And it's funny because it opens when the membrane voltage goes down. It activates. The activation gate flips open. All the other channels we've talked about, all the other channels I know of that have activation gates, they activate when you get depolarization. This one is the opposite. The voltage comes down, you get repolarization, and it opens. But it opens slowly, okay? And as it gradually opens, it allows sodium to come in through the channel. It also allows potassium to go out, but mostly it's sodium in, and so mostly what you get is a depolarization. And the more open pacemaker channels you have, the faster that depolarization takes place during phase 4, okay? So during phase 4, the voltage comes down, your activation gate flips open, but it's really slow. And as it slowly opens more and more, your voltage comes up until you hit threshold and you throw another action potential, and that's how your SA node works, all right? These sodium channel blockers, in addition to the refractory period effect that Dr. Broderick talked about, they also apparently block the pacemaker channel. And so what happens is you get a slowing of this phase 4 depolarization, And so that can be very handy, particularly in the AV node, when you're talking about how quickly you allow those action potentials to get through, okay? So sodium, I'll talk about that in a minute. The sodium channel blockers, what they do is they have this effect upon the rate of firing in these tissues, and they decrease automaticity. And that can make them handy for supraventricular arrhythmias, all right? The reentrant mechanism has to do with the fact that you've already got this beta pathway. Remember, we're coming down, we're splitting at X, the alpha comes around, but then this slows down during the beta pathway. And the slower it is, the more likely it is it'll hit this alpha pathway and re-excite it, because it'll be more likely that that alpha will have repolarized. In this case, you would go, well, this is why sodium channel blockers stink, class 1s stink. You go, well, slowing it down more, won't that make it even more likely to re-excite? The theory is that you slowed it down so much in this diseased tissue in the beta pathway that if you slow it more, you just stop it, and it just terminates. And so the idea is that you get termination in this pathway, that decreases reentry. Okay, so you have a couple of different mechanisms here. You have blockage of the pacemaker channel, which is decreasing automaticity, and you have this decrease in reentry here, which can theoretically stop some arrhythmias as well. Okay, so I think that's all I've got. I'll hand it back to you. The class 1A, in addition to the sodium channel blockade, they block potassium channels, and that's why you get this lengthening. And so that will increase the refractory period in your alpha pathway and help with reentrant mechanisms as well, okay? So if this does get through the beta pathway, the theory is that you've lengthened this plateau and you still left it refractory for a longer period of time. Now, where this gets confusing, and again, another reason why these class 1s stink, is when you look at the class 1B and it shortens that plateau and you go, what the heck? Why would you want to do that? And so, as you might guess, you're using the class 1B for a different purpose, and I think we'll go to the 1Bs in a minute. But this is a classic example of why these are so confusing. They have a lot of different effects. They're not particularly specific. You thought the class 3 were bad and they were doing all these things. These things do a lot of different things too. And they, in some cases, they do the opposite thing. So how can it be an anti-arrhythmic and do exactly the opposite? We'll talk a little bit about that, okay? Thanks.
Thanks. So again, just as Dr. Shannon alluded to, the classes are becoming more and more promiscuous, I think is a good word, because they're not actually following the Vaughan-Williams classification, which is, we still use it. I don't think there's any other way to organize it. There's a new article relatively recently in one of the cardiology journals calling for the abolishment of the Vaughan-Williams and a new classification scheme. It hasn't been adopted yet, which is why I didn't teach it. But I agree with them. It doesn't really make sense. So let's kind of look at these class 1 agents, which are basically sodium channel blockers. The differences are basically addressed in terms of the potency and their ability to kind of slow the conduction velocity, okay? And so the 1C agents are the most potent, okay, in terms of their clinical or physiologic outcomes. The 1B agents offer the least potency, all right? And the 1A agents are intermediate in terms of their potency. Obviously, when Vaughan-Williams sat down and classified these drugs, A, B, and C were not basically based on potency. They were based on, the refractory period. And so they were really looking at kind of the old-fashioned kind of patch clamp physiology in terms of what the cells look like ex vivo. So what are these sodium channel blocking 1A agents? Quinidine. Okay, quinidine will block the activated sodium channel. It'll slow that upstroke of sodium and it'll prolong that QRS interval. We will use quinidine to maintain normal sinus rhythm in patients that have atrial flutter or atrial fibrillation. Based on pharmacokinetics and pharmacodynamics, the nuances to quinidine are listed here. Side effects and toxicity, GI, nausea, diarrhea, vomiting, in mostly a third of the patients. Headache and dizziness are associated with toxicity. So, as we demonstrated, quinidine is not a pleasant drug to be on, to say the least, but, it definitely will block that 1A sodium, or that sodium channel from the 1A class. Probably another 1A agent that's a little bit more clinically useful would be procainamide. It's really effective in most atrial and ventricular arrhythmias, and we don't really use this long term. So you don't really see patients on procainamide for 6 weeks. Okay, it'll be kind of a short-term use of a drug during acute MI as a secondary intervention to lidocaine. Okay, so what does that look like? Well, the patient walks in with an MI. They're going to be placed on all those drugs that we talked about last week. Okay, and in the back of your mind, as the clinician, you might be worried about an arrhythmia starting at this point, right? Because at this point, you don't know how much necrotic myocardium exists. Is this a mild heart attack or is this a major heart attack? Okay, and so how do you assess that? I guess we'll review pathology as well. How do you know if the patient had a mild or a major heart attack? What types of tools are you measuring? Well, one thing you can look at is the left ventricular ejection fraction. Okay, that'll tell you how much blood is being pumped out per unit time. And the other thing that you can look at is maybe some type of imaging on the heart, whether it be ultrasound, CT, or some type of structural measurements. And you want to look to see if that ventricular muscle's gotten thicker due to hypertrophy. So all of those measurements would kind of feed into that. So this procainamide, essentially what you would be doing, what you'd be using it second to lidocaine, would be kind of, preventing some of these circus movements that might have come about through this dramatic myocardial infarct of cell death. Okay. Also structurally, there will be some ganglion blocking ability to procainamide, but, again, the patient's not going to be on it for weeks. They might be on it for a couple hours. All right. Various routes of administration, both hepatic and renal metabolism or elimination. Long-term therapy, and this is why patients don't take these drugs for very long, is associated with a lupus-like syndrome, which is reversible when the patient stops the drug. Okay. Other 1A agents include disopyramide. These are mostly for ventricular arrhythmias, at least here in the US. If it's used for an atrial type of arrhythmia, you have to use a drug that slows the AV conduction velocity with it, which we'll talk about shortly. There's also anti-muscarinic effects, much more so than quinidine, so it starts to behave like atropine, and the dose guideline is listed there. So a lot of different nuances to some of these drugs. Disopyramidine is a negative inotropic effect on the heart, specifically on the ventricular myocardium. When you use this drug, you can actually precipitate heart failure, okay, in naive patients or patients with pre-existing left ventricular depression. So, as you're kind of assessing the patient, you have to kind of look at left ventricular ejection fraction, which we'll talk about tomorrow, to see if heart failure is becoming manifested. And of course, if it is, this drug is completely contraindicated in heart failure. So even though they may have an arrhythmia, if they've got an arrhythmia and heart failure because of an acute MI, this drug is a no-no. Right? And so really the class 1A agents, quinidine, procainamide, and disopyramidine, are listed here. Okay? And this is just kind of looking at the differences in terms of the clinical pharmacology. All right. Here's another summary chart looking at the electrophysiologic effects. And, in terms of their ability to decrease or depress conduction velocity, they're all essentially equal. And according to their ability to increase the refractory period, they're essentially equal as well. Okay. Nuances come out here, but essentially these drugs are pretty much the same across the board. Okay. So that kind of brings us to the 1B agents, and these are the 1B agents that are associated with the open calcium channel, or open sodium channel?
Yeah, I'm going to talk about that because it's wrong. And it's right in your notes, thank goodness. I made that correction this year. I didn't correct this slide. Let's talk a little bit about why you'd want to shorten the action potential to begin with. Because we just got done talking about the fact that lengthening is good with the type 1As. You guys remember long QT syndrome from last year, and we talked about the fact that if you lengthen the action potential plateau, it can lead to these early after depolarizations, or EADs, and that can cause triggered arrhythmias, which Dr. Shaw mentioned a minute ago, okay? As it turns out, at least in MI, and maybe one or two other diseases, you lengthen the action potential plateau. And the reason isn't because of a mutation in a potassium channel or anything like that. It's got to do with the fact that all of a sudden, these sodium channels that are supposed to activate rapidly and inactivate rapidly don't completely inactivate, okay? For some reason, they have a tendency to want to open during that plateau phase instead of inactivating completely, all right? It's still an area of active investigation. It probably has something to do with calmodulin-independent protein kinase activity, which you don't need to know. But it seems to happen. And so what you get is what they call a late sodium current. It's not a very high percentage of these channels. If it was, you'd die because there are so many sodium channels. But it's enough to make a difference. So in addition to your calcium current and your sodium-calcium exchanger during phase 2, you also have this extra sodium influx. So that makes your voltage hang around more and stay depolarized longer, and it lengthens this action potential plateau, and that can lead to EADs, all right? So these drugs are targeted toward that late current and shortening that action potential plateau so you're less likely to get these triggered arrhythmias, all right? And the way they work, it says that they're open channel blockers. That was my bad. That was my misconception. In fact, these channels are not open for very long, and the vast majority close and inactivate really fast, and they stay inactivated during that plateau phase. And so these drugs actually bind both the open channel and the inactivated channel. And so they're bound all the way through this action potential, and then upon repolarization, they unbind, and they allow the channel to open again. But they're bound during the action potential plateau, and they prevent these late sodium channels from reopening, okay? And so they prevent this lengthening of the action potential plateau. And so that's their mechanism of action. In fact, they're mostly bound in inactivated channels because this opening is so brief, there's almost no time for them to bind. And so there's only a very minor effect upon the upstroke of the action potential. You saw that earlier in Dr. Berderic's slide. But the late sodium current is inhibited enough to shorten this action potential plateau. And so that's in theory how these things work, all right? So both open channels and inactivated, they stay bound during the entire plateau. They unbind at these negative potentials, and theoretically, they help you with these triggered action potentials. Okay?
Then as we go through.
I should have mentioned, I'm sorry.
Go
I
ahead.
should have mentioned that the binding is increased when you're acidotic, when you've got high potassium, and of course when you're depolarizing a lot, you're staying depolarized, you're allowing more time to bind. And so these are all conditions that are favored during MI or during an arrhythmia. So it's more likely to bind during an arrhythmia as well, and that makes it effective in diseased tissue, not so effective in normal tissue, which is what you want. You want it targeted toward the diseased areas. Sorry about
No,
that.
that's good. That was a good segue because that's what I was going to say. Lidocaine, when you guys have maybe used, or had lidocaine injected to you for like dental procedures, right? A small amount of lidocaine. When it's in an acidic environment, it actually kind of changes the pharmacokinetic profile, so more of that becomes basically available. And so these drugs, when they're exposed to hypoxic or acidic environments, which would happen, both in terms of, the gum tissue itself, but also in terms of an acute MI, they actually work better. So you get a really good diffusion of this drug through the acidic tissues. And so lidocaine is probably the one that's most clinically relevant, especially during the acute phases of MI, and it's a 1B agent, of course. And so it'll block both the inactive and the active sodium channel with really fast kinetics. And the more acidic the environment, the faster the kinetics. That inactive state block is going to ensure that there's a large effect on cells with really, really long action potentials, and those would be the Purkinje fibers, the ventricular myocardial cells themselves, and then eventually the atrial cells. So where do we see them? They're used to basically abolish arrhythmias that are occurring during the acute MI. Okay, so in terms of the MI, you'll see STEMI, you'll see ST segment elevation on the EKG, okay, but you'll also see typically ventricular tachycardia along with it. And so lidocaine would be given IV, okay, and it will stop that ventricular fibrillation. And so if you don't stop it, then this MI now progresses to cardiac arrest, right? So we're basically in this zone of the patient's physically lying there, STEMI is occurring, okay, and they're tachycardic, and the ventricular muscle is just going crazy, all right? And so again, this is given IV. Out of all the 1B agents, lidocaine is the least cardiotoxic, okay, which is why it's so prevalent. It may precipitate hypotension, okay, but again, these patients are typically, this is during the heart attack, this is kind of the least of your worries. So very, very large boluses of this, especially in patients that have pre-existing heart failure. So maybe if this is a recurrent STEMI, this is their second heart attack, as you'll soon learn tomorrow, they'll already be in stage 2 heart failure. Okay, there will be some neurologic effects, but again, this is this isn't a drug that they're going to be on for 6 days. They'll be on it for 5 or 6 hours until they're stabilized. There will be some maybe neurologic effects. So anywhere from lightheadedness to maybe hearing disturbances, all the way to convulsions. So the side effect profile is quite wide, and it's all stemming from sodium channel blockade. There's extensive first pass metabolism, which is why we don't give it orally. Of course, we would like to have its major effect at the time of the MI. So again, we prefer the IV, but you can see loading doses to basically have the more potent outcome. Higher doses can be tolerated in patients with an acute MI, and that's typically what is seen clinically. Other sodium channel 1B agents include mexiletine. It's a congener of lidocaine, and it avoids the first pass hepatic metabolism, and so you can give it orally. This can be used to terminate ventricular arrhythmias. Of course, there will be some CNS side effects as well. So this would be kind of more for the kind of persistent arrhythmias that would occur, kind of in like a non-emergent situation, but still would need to be clinically addressed. Okay. Phenytoin, don't worry about. We'll talk about phenytoin later. This is more of a CNS type drug, but it does have some anti-arrhythmic ability, and a lot of this is kind of used off-label. So, it is technically a 1B agent, but you see it more used in the CNS diseases. And again, some more summary slides of looking at these. And this is coming from a cardiac review, an anti-arrhythmic review article that was published a couple of years ago. All right. So now as we go through, now we're going to talk about the class 1C sodium channel blockers.
Don't sit down, this won't take long. In addition to all the normal sodium channel effects, the 1C increased the refractory period in the AV node. So that means it widens this action potential and keeps it depolarized longer, which means if you have a supraventricular arrhythmia like atrial fibrillation or something like that, it makes it harder for those action potentials to get through the AV node and excite the ventricle. So they can be effective for these kinds of arrhythmias. Unfortunately, mechanism unknown. Okay, so take that for what it's worth. It does it, and we can all be grateful, I guess. But nobody knows yet exactly how that works. Okay, that was pretty short.
That's the punchline. Okay. And the main drug here is flecainide. And so, we think it blocks sodium-potassium channels, and the kinetics are relatively slow. It doesn't really affect the action potential of the QT interval. So what kind of patients would get this? A patient with essentially a normal heart that has atrial arrhythmia. So remember, atrial is supraventricular. And it'll kind of suppress the premature ventricular contraction. So I always think of this particular drug as kind of like the stoplight. And so if the atrium is the point where all the traffic exists, and the ventricle is kind of like the country road, the main thing that's preventing the traffic from getting to the open country road is the stoplight, okay? And of course in Chicago there's many stoplights, but there's just one, okay? And so these drugs are great, or this drug is great for some of those atrial arrhythmias that are kind of driving or pushing some of the other cardiac pathologies. Another 1C agent is propafol. And again, this is structurally similar to propranolol, okay, so there is some beta blocking ability, and same indication, supraventricular, also known as atrial arrhythmias. The spectrum of action is kind of similar to quinidine in terms of its sodium channel blocking kinetics. Patients will complain of a metallic taste and, of course, constipation. Those are the two main common side effects, but arrhythmias can be exacerbated. And so, propafol can be used with severe caution. Morphine, this is an old drug. This will only be available probably in like the Kazakhstan or some former USSR republics. We teach it just because it was cool from a kinetic standpoint, but they took this drug off the market, so don't worry about morphine. He's gone. Okay, and so really it's just flecainide and propafol. Okay, and different elimination approach. So, if you're looking at specific nuances of patients, there's really just two drugs to kind of choose from. Same here, summary. Okay. And so, one of the ways in which they've differentiated some of these drugs are, which drugs have the most potassium blocking, and which drugs have the most sodium channel blocking. And so this is kind of unique, or I like this slide. The class 1B agents have the highest degree of sodium blocking and the lowest degree of potassium blocking. In contrast, the class 3 agents, of course, have the highest potassium blocking ability and practically zero sodium channel blocking ability. And in between are this no man's land of class 1A and class 1C agents, which have, obviously potassium channel blocking, but also sodium channel blocking as well. So this is where kind of they overlap. And that just kind of puts things into kind of visual perspective. And of course, there's examples of each on the bottom axis. All right. So let's kind of return back to the ventricle. And here's a summary chart looking at the different phases and the responsible ions, associated with each phase. And of course, based on the shape, we know this is ventricular muscle. I want the thing to go forward. Here we go. Okay. And the reason we talk about, or I remind you about the ventricular muscle, is because now we're going to look at the beta receptor again. Okay.
So, you guys remember how this works? The beta receptor, I'm sure you've been through it already this year. What you get here is binding of norepinephrine to the beta-1 receptor in the heart, right? You generate cyclic AMP through increased adenylyl cyclase, and the increased cyclic AMP activates pKa, and you get all of these effects on these channels that lead to an increase in heart rate, right? You activate L-type calcium channels, and you increase pacemaker channel activity. That brings you up to threshold quicker in your SA node and increases the rate of firing, okay? And so by slowing this phase 4, you can decrease automaticity, right? You decrease the rate at which you hit that threshold. And that can be a key feature here. I mentioned sodium channel blockers before in this regard as well, in that blocking the sodium channel can decrease automaticity as well. The reason why calcium channel blockers are so effective in the AV node, in particular in the SA node, is because this upstroke is carried by calcium. There are no fast sodium channels. So you guys will remember, we talked about things that affect the rate of action potential propagation and the threshold potential. And the number of sodium channels in a typical nerve or ventricular myocyte would have a big effect on that. If you reduce the number of sodium channels, you decrease the rate of propagation, you increase the threshold potential, and of course, you guys know you give a local anesthetic, you give a sodium channel blocker, you'll increase the threshold to the point where you feel no pain, you get no propagation at all. So in the AV node, this is all calcium channels. But if you've got an ectopic area where you've got some cells that are generating action potentials when they shouldn't, Purkinje fibers are particularly well known to do this. In other words, you've got an abnormal area that's hitting threshold on its own and generating action potentials on its own and causing arrhythmias when it shouldn't. Okay, and again, Purkinje fiber is well known to do this. Then those myocytes are dependent upon sodium for that upstroke. So if you give a sodium channel blocker, it's going to really affect an ectopic area and decrease the automaticity, decrease the rate at which, or it's going to really increase the threshold potential hugely. And so it can really be effective in those kinds of arrhythmias. These calcium channel blockers can be effective as well, but they're going to be more effective in the AV node where that calcium channel, these class 2 are going to be effective in the AV node where you're slowing the slope of increase and you're also blocking these calcium channels. And so you're increasing the threshold potential there as well. And so that's going to help decrease automaticity in these areas, and it's going to decrease the rate of propagation of action potentials through them, okay? And that's what I've got right here, increased AV nodal delay. Decreased conduction through the AV node, or increased AV nodal delay. So you might imagine why that might be handy, once again, in supraventricular arrhythmias, where you're trying to keep an atrial depolarization, an atrial fibrillation from getting through to the ventricle. You keep the AV node depolarized longer, and at the same time, and you slow the rate of propagation through that tissue. That can be very helpful. Okay, and again, decreased triggered arrhythmias largely through the effects of the L-type calcium channels. So again, we're talking mostly about EADs here, and delayed after depolarizations come after repolarization. It turns out that both of these are largely dependent upon L-type calcium channel activity. And so blocking the L-type calcium channels can prevent EADs. It can prevent that upstroke at the end of the action potential. Okay? So that's what these are mostly good for. Okay? Because of their effects on the pacemaker channel, because of their effects on the L-type calcium channel, you decrease automaticity in tissues, and you increase the AV nodal delay through that calcium channel block, okay? And the triggered arrhythmias as well. L-type calcium channels, again, mostly responsible for those EADs. And it turns out that the calcium channel current has a big effect on delayed after depolarizations as well. That is depolarizations from rest, okay? Clear? Or just babble? We okay? Okay.
Actually, let's take a break, because we went well over an hour. Well,
okay.
Why don't we take like a 10-minute break?
Before you go, reduced oxygen demand and myocardial ischemia, I think that makes sense as well, okay, with beta blockers. Sorry, go ahead.
Yeah. Actually, just stay on this, because I want to put a few things on here because we've been talking about beta blockers for the last 3 days. So I'm going to tie everything in.
You didn't cover that very well.
That's okay. We're getting tired. That's why. Let's take a break. Because when we start, we all need a break. Good. All right. Okay. Almost done. All right. Guys, start. So just kind of a few things about beta blockers, and Dr. Shannon's right. They treat almost everything, right? So every pathophys lecture that we've talked about in terms of the heart, we've brought up the use of beta blockers, right? From, hypertension, myocardial infarct, coronary artery disease, now anti-arrhythmias, and heart failure tomorrow, okay? And so we had really focused on the mechanism of action here in terms of what the beta receptor does upon stimulation and basically opening up calcium storage inside the cardiac myocyte. But I think maybe the nuance here is that, perhaps you didn't realize that, once this message had gotten inside the cell, that now different ions, different ionic pumps have been affected too. And so why do we say that, post-MI, the patient must be on a beta blocker? We said that, in terms of their survivability, we've got clinical data that backs up that beta blockers prevent recurrent myocardial infarct, okay, and stop sudden death that was associated with patients that actually survived a myocardial infarct. Well, the sudden death was really brought on by exacerbations due to heart failure, which were driven mostly by large portions of ischemic tissue that was unresponsive to electrical stimuli, which produced arrhythmias. Okay, and so back in the day, if a patient survived a myocardial infarct, okay, the arrhythmia would manifest itself shortly thereafter. And so by putting a beta blocker on board, you're actually kind of preventing the pathogenesis of an arrhythmia to manifest itself, because you're basically altering the ability of this influx of calcium to control these ions as well, okay? And so when you have an increased AV nodal delay because of excess amounts of norepinephrine and so forth, that can be the thing, one of the precipitating factors that actually can trigger some of these arrhythmias. So that's one of the other things that I just wanted to recur. And then again, this notion of reduced oxygen demand due to myocardial ischemia has been kind of the underlying theme for all of these pathogenesis discussions in terms of how the beta-1 receptor, if it's left open, can actually kind of produce a lot of these arrhythmias and diseases. Okay? And so, again, we're basically looking at the amount of calcium that's inside the cell. I wasn't wondering why I put this in here. And we're looking at the ventricular myocyte, especially. Okay, and so calcium plays a major component in terms of membrane potential, and beta blockers basically prevent that huge influx of calcium that's associated with norepinephrine binding to this receptor. So when you give a patient a beta blocker, obviously heart rate's going to be reduced. We're going to reduce the amount of intracellular calcium that's available within the myocardiac cell, and we're going to inhibit these after depolarizations. And that's going to be kind of the thing that's driving this mediated automaticity. So mechanism of action, what they do, they block the beta-1 receptor, but they also have what's called direct membrane stabilizing effects. So these are beta blockers that have some sodium channel blocking activity. And so I don't remember one of those Goodman and Gilman summary tables that I'd put up, I think maybe in the first heart lecture slide series, was, it had a whole list of beta blockers, and the first column was membrane stabilizing effects. And that's the ability of this beta blocker molecule to inhibit sodium channel activity through beta-1 inhibition. So this is kind of a downstream kind of effect. Other nuances to beta-1 receptor antagonists include ones that have intrinsic sympathomimetic activity, deemed ISA. So these are beta blockers that have partial agonist activity. Okay, so again, and I still get questions about this, even from third year and fourth year medical students. What the hell is a partial agonist? All right, go back to real fundamental pharmacology. Okay, an antagonist produces zero physiologic activity, right? An agonist produces a magnitude-fold higher increase in physiologic activity. So let's just say, to make it simple, antagonists produce an output of 0. Agonists produce an output of 10. Partial agonists, or drugs that have intrinsic sympathomimetic activity, have an output of 4 or 6. Okay? So one could argue, well, how did they make partial agonist drugs? Well, they tried to make a beta blocker, and it was crappy. All right? So it didn't annihilate the beta-1 system, okay? It didn't stimulate the beta-1 system, okay? It was a mediocre antagonist. And so we found clinical use for these. We'll discuss the mediocre antagonists tomorrow when we talk about heart failure, because that's actually where they start to kind of demonstrate some of those effects. Of course, on the electrical side, beta blockers will prolong the cardiac action potential. That's kind of like the basis for this lecture. You've heard of some of these already. Esmolol, what do you guys know about Esmolol at this point? Short acting, only given IV. Guess when we're going to use it? Today, okay, in the antiarrhythmic patient. Sotalol we'd already talked about, okay? So this is both a beta blocker and a potassium channel blocker. Okay, and then ace-butalol and propranolol, of course, are the more, the grandfather kind of beta blocking agents that are neither specific for beta-1 or beta-2, but still share some of these mechanistic approaches that we're going to use to target this system. All right. And so this is kind of a nice summary table, because now we're looking at whether or not this beta receptor and blocker, quote unquote, is indeed beta-1 selective. And which ones are beta-1 selective? Ace-butalol to some degree. The major beta-1 selective drugs, and you know these by now, are atenolol, metoprolol, and esmolol. Okay, and so atenolol and metoprolol are essentially more or less the same indications. Esmolol is one that's short-acting, okay, very weakly soluble, and its half-life is 9 minutes. Okay, so you don't see patients on esmolol for 20 days or 20 years. You'll see them on it for maybe two or three days while we stabilize them. And this is, again, during the acute MI phases when you really want to have tight control of that beta-1 receptor. All right? You don't want some of these arrhythmias to manifest themselves. This class 1, what does that refer to? Well, this refers to the beta blocker to have membrane stabilizing activity. So what they're really comparing is this beta blocker to act like a sodium channel blocker. That's what this class 1 indication means. So you could just write that on there. So which one of these beta blockers acts like a sodium channel blocker? Ace-butalol, carbidiol, indolol, and propranolol. Okay. Which of these beta-1 antagonists have intrinsic sympathomimetic activity? Which ones can act like a partial agonist? Okay. Ace-butalol, labetalol, and pindolol. Okay? So as you kind of go through this, this continuum, and really it's a continuum. These are not separate diseases in the cardiac unit. It's a continuum. A patient can walk in with hypertension in the emergency room. They can have a heart attack in the emergency room, and they can leave with heart failure. And during that period, they may have had an arrhythmia for maybe 3 hours. Okay? So this could all physically be one patient over a span of 50 hours. Okay? So that's kind of, again, kind of a different look at our beta blockers. And our molecular target was really inhibiting the amount of calcium inside that myocardial cell. All right? And there's another drug class, the calcium channel blockers. Oops, I keep hitting the flash drive with my thigh. There's another class of drugs, I didn't hit it. There's another class of drugs that inhibit calcium, and those are the calcium channel blockers. And so mechanistically, it's very similar, but with some slight nuances.
Very similar. So I'm going to run back to this slide really quick, which was sort of out of place up here.
We'll end it, and we'll just go.
No. No. Farther down, farther down. There you go.
There we go.
All right. I don't need to do that.
That's it, go back.
Yeah. Let's see. So I already talked about this with the beta blockers, really. Your calcium channels are sodium channels. In the SA node, you have calcium channels instead of sodium channels, and they mediate that upstroke. So if you block calcium channels, it's like blocking sodium channels in a nerve. You increase the threshold potential. If you increase the threshold potential, it takes longer for this phase 4 to reach threshold, and therefore it slows your heart rate. Makes sense, right? And you decrease the conduction velocity through the AV node. So if you have a supraventricular arrhythmia, you'll keep that AV node refractory for a longer period of time. Your atrial fibrillation and action potentials have a tougher time getting through, okay? And I bet that's it. Nope, yep, that's it. There you go.
Okay. And so we've been talking about the calcium channel antagonists. And so our target here is going to be to reduce the AV nodal conduction velocity, and that's going to result in a much larger P to R interval on the EKG. And our prototype drugs include verapamil. Ooh, is that coffee? You good? Our prototype was verapamil and diltiazem. At least it was towards the end. Okay. So let's just quickly kind of summarize verapamil. Verapamil blocks those active and inactive L-type calcium channels, and that's going to have direct effects on the SA and the AV node. So now the tissues are going to fire frequently. The activation is going to depend on the calcium current, and these tissues are going to be less completely polarized at rest. We're going to see peripheral vasodilation. Diltiazem can be useful in supraventricular arrhythmias, so atrial arrhythmias, and also in the context of high blood pressure and angina, right? And so if the patient has an arrhythmia, angina, and elevated blood pressure, diltiazem or verapamil would be a good drug to use. Okay. How about some miscellaneous agents? Adenosine, magnesium, digitalis. These don't fit into the classic kind of Vaughan-Williams classification scheme, but they're really useful in terms of their ability to be anti-arrhythmics. Okay. Adenosine is a naturally occurring nucleotide. It's administered as in a rapid kind of IV bolus, and this will really, really quickly terminate those supraventricular arrhythmias that are re-entry. All right. Adenosine is a really good friend of mine because it saved my son's life. My son had an SVT about 9 months ago. He's 5. He came out of the play bin at Chuck E. Cheese holding his chest. I thought he had fallen, and I checked his heart rate, and it was 220. I mean, I couldn't even count that fast. I knew it was really high. So we took him to the emergency room. The vagal maneuver did not work. His heart rate was 275 when we brought him in. And this adenosine, so the vagal maneuvers did not work. And so if you stimulate the vagus nerve through a whole bunch of different muscle exercises that the pathophys people can shed more light on, you can convert the patient out of an SVT, supraventricular tachycardia, or atrial arrhythmia. So this drug very quickly took that SVT away. He was back to normal in about 1.5 minutes, 2 minutes. Which is about the amount of time, if you give something IV, it takes to completely kind of circulate through the body. Mechanistically, how does this drug work? Well, a couple of different things. So it'll activate the acetylcholine-sensitive potassium channel, so that it's really kind of a supravagal maneuver in terms of a chemical itself. You'll see mechanistic effects on the atrium and the SA node, as well as the AV nodes themselves. It'll hyperpolarize those tissues. It'll shorten that action potential duration, which is graphically depicted on this slide. And it'll slow the automaticity rate, okay? And so here you see an inhibition of intracellular cyclic AMP, and that's going to inhibit norepinephrine binding, and you'll see a reduction in calcium current, and so that will increase the AV refractoriness. And so adenosine, great drug, it's cheap. It goes in, it terminates the SVT, and very little to no side effects afterwards. So this is kind of a nice drug compared to all the other antiarrhythmics that exist. You can also see this drug used for kind of controlled hypotension, to kind of induce hypotension in a cardiac-related surgical procedure. And so again, this is a great drug because it's got such a short half-life. The side effects and the toxicities are short-lived anyway. There is a drug type of interaction with methylxanthines, which include theophylline or caffeine. These block adenosine receptors, and so larger doses would be needed if these drugs are co-administered. And so luckily my son does not drink a lot of coffee like I do, so he did not need larger doses of adenosine. Okay. Magnesium, you can see magnesium being used, and this is really efficient specifically to terminate torsade de pointe, all right? Here you see kind of suppression of early after depolarizations, or EADs, because of the blockade that magnesium has on the sodium-calcium channel. And then this is also kind of dose dependent. And so look at really, really high doses of just magnesium. So this is just, Epsom salt, right? High doses of magnesium can induce cardiac arrest after respiratory paralysis. And so small amounts of magnesium will be observed on changes in the EKG, but especially with torsade de pointe, this is a really effective, cheap strategy to kind of treat some of those conditions. What are the drugs that are known to induce arrhythmias? Well, when used inappropriately or at high doses, digoxin or digitalis, beta blocker withdrawal. So we talked about, if the patient's on a beta blocker for whatever, any of these cardiac diseases, and they decide, hey, you know what, it's been 10 years since my heart attack, I feel great, I've lost weight, I'm going to stop taking my beta blocker on Tuesday, because why not? If they have an abrupt withdrawal of that beta blocker, you can actually see these arrhythmias become more and more evident. So if a patient needs to go off of a beta blocker for whatever reason, whether it's their decision or yours, they need to be tapered off of it very slowly over the course of several weeks. One of the things that you should remember, and this is a good rule of thumb for all pharmacology, is that when you supply an antagonist, doesn't matter what kind, the body's corresponding response to that is an upregulation of whatever receptor you're trying to get rid of. Okay, or trying to silence. So in the case of a beta blocker, 20 years on a beta blocker combined with abrupt withdrawal is going to produce a really hypertensive patient, okay, and the heart rate's going to be through the roof. Okay. Other drugs that are known to induce arrhythmias include theophylline, which is one of those xanthine oxidase inhibitors used basically in asthma. Verapamil, diltiazem, quinidine, flecainide, all these drugs, although they are anti-arrhythmic medications per se, when you give them inappropriately or if the patient has some underlying dramatic structural heart damage, you can see some of these agents induce arrhythmias. So what does that tell you about starting an anti-arrhythmic medication in a naive patient? Naive meaning never been treated before. Okay. Do you tell them to fill the prescription at their pharmacy and wish them good luck? Or do you keep them in the hospital? You should probably monitor them for at least 24 hours with EKG to kind of make sure none of these pro-arrhythmias are going to be induced by some of these drugs. And that's what they do. And so many times when a patient is put on an anti-arrhythmic medication, there is some underlying cardiac pathology anyway. So you have to work them up, and that usually takes some time. So they're usually in the hospital anyway, okay? Now my son, when he had the SVT, he was not hospitalized or he was not admitted. He was only in for maybe 2 or 3 hours. Heart rate fell to normal. There were no side effects and toxicities. EKG looked beautiful. It was the end. So there was no reason to hospitalize him. So let's talk a little bit about digoxin. And so this is kind of this is a weird drug that you don't really know where to put it. It used to be kind of frontline therapy for a lot of different diseases, and it's kind of fallen out of favor for good reason. And so digoxin comes from this really nice plant that actually grows in my garden. It's the only thing that the damn rabbits won't eat. So, it self-seeds everywhere. And it is a cardiac glycoside. And so basically it's poisonous, okay? It increases the slope of phase 4, okay, and it'll increase the rate of automaticity, especially in the context of low potassium levels, all right? Mechanistically, we say this is a sodium-potassium ATPase pump inhibitor, all right? And here's the sodium-potassium ATPase pump, and digoxin sits in there, okay? Where do you see this drug used? Well, for controlling ventricular rates in patients that have atrial flutter, atrial fib, with underlying heart failure, okay? So it's a very specialized or specific patient population. It has a very narrow therapeutic index, so there's a very fine line between dosing the patient and killing the patient, okay? But it will decrease AV nodal conduction, okay? So here's that calcium sodium exchanger, okay? So here you see calcium and sodium being moved out across their gradients, and this ATPase pump relies on the sodium gradient to pump in potassium. Okay? And so what digoxin or digitalis does is it actually inhibits the activity of this pump. Okay? And so this drug now makes this cardiac muscle positively inotropic. Okay? So if a beta blocker reduces the amount of the amount of calcium inside this myocardial site, it's a negative inotrope. Okay? Digitalis increases the amount of calcium available, okay, and makes it a positive inotrope. Okay? And this is why it's used in heart failure. Okay? And we'll talk about the indications of digitalis or digoxin in heart failure, but specifically it's heart failure patients that have underlying arrhythmia problems. It's not just your standard of care for heart failure patients. And in fact, since we're on digoxin anyway, when you look at the clinical data for digoxin, patients that are on it typically don't fare better being on this drug, which is unique because all the other drugs, beta blockers, ACE inhibitors, diuretics, aldosterone antagonists, all of those drugs actually have clinical data that says when you put cardiac patients on them, they live longer. Digoxin, some of the data actually says they live shorter periods of time, but you really have nothing else to treat them with. So this is kind of a unique drug class. It's falling out of favor in terms of its number of prescriptions written per year, but it's still clinically relevant. There are still physicians who will use this drug for, again, for the specialized population of patients, and you'll see them in the wards. You will probably not be writing new prescriptions for digoxin because it does require some experience. And so, you know, if you do decide to elect to put a patient on digoxin, you know, the attending, I'm sure, will be kind of over your shoulder to help you manage them because it is a little bit tricky. You'll see AFib and aflutter for this drug used for, you know, kind of controlling the rapid ventricular rate. It has other outcomes due to its mechanism. It's going to impair ventricular filling, okay? And it's going to decrease the filling time, which is going to reduce cardiac output, okay? So from a heart failure perspective, that doesn't bode well in terms of what we're going to talk about tomorrow with heart failure. But again, remember we talked about the heart failure patient with an arrhythmia, which is a specialized group of patients, okay? We have to control ventricular tachycardia because eventually, if it's left untreated, it's going to lead to heart failure, which is why we have to use this drug, okay? So digitalis is useful for kind of controlling that ventricular rate when it's being driven by a very fast-paced atrial rate. So here the atrial tachycardia is driving the ventricular tachycardia, which is going to reduce cardiac output, okay, and then exacerbate heart failure. So see how all four of those are connected? That'll become a little bit more evident tomorrow when we go into the nuances of heart failure. All right. Mechanistically, digoxin can also activate the vagal efferent nerves, all right? And this is the one that's under parasympathetic control. So vagal activation, again, this is the 9th cranial nerve. It's going to reduce conduction of electrical impulses, and this is all mediated by acetylcholine. Okay, when this occurs, fewer impulses reach the ventricles, and then the ventricular rate falls or plummets. All right. Digoxin can also increase the effective refractory period within the AV node. So there's lots of mechanisms of action of digoxin, and this is why this drug will work, but it's so problematic in terms of management. All right. Here's again some of these mechanisms of action. So it will increase intracellular sodium. That leads to the accumulation of intracellular calcium, which leads to basically more calcium being available inside the heart for increases in contractility. So it's positively inotropic. Will inhibit the sodium-potassium ATPase in the vascular smooth muscle, and that'll cause depolarization. And so here you'll see smooth muscle contraction and vasoconstriction. And so lots of different mechanisms of digoxin. And as I said, relatively a narrow therapeutic index, so it's a really unsafe drug. It's got a long half-life. It sticks around for a long time. There's numerous drug-drug interactions, and it can actually, in terms of alterations in patient status, can actually precipitate an arrhythmia, which is why you need experience if you're going to manage a patient on this drug, especially in patients that have atrial tachycardia and AV nodal block. So, you know, we talked about the patients who can get it, who can't get it. Patients who are or can be at any time low potassium. Patients who have AV block or the Wolff-Parkinson-White syndrome, which is a rare syndrome. And basically, we're going to, if we look at our left ventricular ejection fraction curves, looking at, this is pressure versus volume. You showed them this this loop in physiology a million times, right? So now we're going to actually use this as kind of a target. So a lot of our drugs that can increase contractility, or drugs that are positive inotropes like digoxin, can actually kind of shift this curve. And so you can see what that looks like in each of these different cartoons. And this is kind of a nice summary chart looking at all of the different molecular or physical targets in terms of anti-arrhythmic drugs. So in the context of sinus bradycardia, okay, so if the patient's got very, very low heart rate, we can use atropine, okay, IV, and it's going to have a negative or an inhibitory effect on acetylcholine in this SA node, and it'll rescue the bradycardia so that we restore normal rhythm. If we've got ventricular and supraventricular arrhythmias, we can use class 3, class 1A, or class 1C drugs, okay? And so here we're going to mechanistically favor targeting the phase 0 and the phase 3 slope. Ventricular arrhythmias can be treated successfully with class 1B agents, and lidocaine was really kind of our favorite in that category. And supraventricular tachycardias can be eliminated with adenosine, digoxin, or verapamil, and we'll favor adenosine just because of its reduced likelihood of drug-drug interactions. Stress-induced arrhythmias can be managed by long-term beta blocker activity, okay? And let's see, I think we've got everything else covered here. And more drugs can inhibit the refractory period. So this basically kind of combines what we've been talking about in terms of a summary chart or an idea map looking at all the different molecular targets. Let's kind of quickly go through some of these. So the class 1A agents are going to block the sodium channel, right? So class 1A, B, and C are all going to block the sodium channel. The differences between 1A, B, and C are the primary sites of action. So B and C primarily are going to be affected, or are going to primarily affect the ventricular tissue itself. The class 1A agents will also affect atrial tissue. Okay, and then the drug examples are listed here. The class 2 agents are the beta-1 antagonists. Those are going to primarily affect the SA and the AV node. All right. Your class 3 agents are your potassium channel blockers, and those will go after atrial and ventricular muscle itself. And your class 4 agents, like the class 3 agents, because of their effect on calcium, are going to go after the SA and the AV node. And then the prototype drugs are listed here. All right. And then a lot of this is just more summary stuff. I think I just put these in as extra diagrams. One thing I did want to remind you was, and this is coming from Dr. Shannon's notes as well, is that, you know, this is kind of the flow of conduction, or of electrical conduction through the heart. And if you were to essentially eliminate the SA node, what's the next tissue that's going to fire? You guys remember this? Is this the first one? Yeah, this is the first one. You guys remember this? Yeah. Yeah, and so then if you eliminate the AV node, what's the next one that's going to fire? The Purkinje's, right? Stop me if I'm wrong, Tom. And then if you go down, and if you eliminate the Purkinje's, then the ventricular muscle can fire, right? Probably.
I don't think it comes to threshold.
Yeah, conceptually, but physically it probably doesn't happen.
Purkinje's, really, it almost doesn't make sense to me that they're excitable either. Apparently, they do rise very slowly in the threshold on their own. The ventricular won't unless it's diseased muscle.
Okay. Which may happen in our MI patient.
I think it might.
Yeah, right. Okay. So, you know, and then these are just kind of like self-study things that you can kind of review some of the different pathophys. Do you have anything to add to some of these here, Tom? I mean,
I think so. I think most of it's in the notes.
Yeah.
All these figures came from, we just kind of not because we thought they were done.
Yeah. All right. So that's the anti-arrhythmic lecture in terms of the receptors and then the drugs that alter them. Digoxin?
Yeah, and on one of the slides about it, you said something about.
Mm-hmm.
Why it decreases ability.
Yeah, and so what happens with, let me see if I can bring it up. Is it 71? So digoxin is weird. Basically, it's going to alter the amount of time that it takes to fill this. Even though it's a positive inotrope, it's going to alter the amount of time that it takes to fill it. Do you?
Yeah, but heart rate becomes really rapid. Remember, when you're exercising, you increase heart rate, you still got time to fill because you're most of the way there pretty quickly. By limit filling time, you won't have time. It doesn't happen when you exercise with a treadmill or anything like that. But a drug could induce a
Yeah, and that makes sense, but it's not the Johnson lower.
tachycardia there, I assume. By AFib, if you go back to that.
Yeah, it's going to lower heart rate.
Just do this debate.
Mm-hmm.
Yeah, you also said, yeah, increase.
It activates the vagal and produces conduction.
Yeah, so this is, it's not actually going to affect heart rate. It's not going to raise it like really out the.
So which slide do you just looking at when you say reduce filling time?
I think so.
Back to the slide you had up where it said they reduced filling time. There you go, that one.
71.
At AFib or color. There
Yeah.
you go. I think he's talking about
Disease state.
the disease state.
Yeah. Yeah, and that's one key concept about digoxin to remember is that normal patients are not getting this drug. There's so much pathology, cardiac pathology in these patients that you may be thinking of, oh, how do I return it to normal? Or my starting point is normal. Your starting point is not normal. These patients have arrhythmias, also have heart failure, and there's large areas of the myocardium that's unresponsive, both electrically and medically, in terms of its ability to contract and dilate. All right? Cool. All right, guys. We are done. I'll see you guys tomorrow for heart failure, and then we're done. Let me pause it. Oh, stop.